Hello, good morning, and welcome to one more classroom. This is a very important topic, and we have a very elegant speaker, Dr. Manish Marda from Fortis Noida Hospital, New Delhi, and he'll be talking on fluid management, a very important topic, the management of traumatic brain injury patients. I introduce Dr. Manish Marda. He's here with us. Dr. Manish, what are you going to talk on this fluid management and traumatic brain injury today?
Good morning, everyone. Fluid management is an integral part of managing a polytrauma or traumatic brain injury patient. So that I would be talking how to manage if the patient is having polytrauma along with traumatic brain injury or isolated traumatic brain injury in terms of fluid management.
Are you going to include a transfusion as well in your presentation?
Yes, I will touch transfusion a bit, but I will not elaborately discuss it.
Okay, quickly I'll go to Dr. Prasanna. And Dr. Prasanna, how do you think this topic is important to us?
It's a very important topic, and I know Dr. Manish very well, and he's going to touch upon
Yes,
the aspects.
Dr.
I'll be eagerly
Prasanna,
waiting
can you
for
hear me?
him to. Yeah, are you able to hear me?
Yeah, you can go ahead.
Yeah, I'm sure that Manish will do justice to it, and I'm eagerly waiting to listen to him.
Okay, Dr. Manish. You can start your presentation, Manish.
Okay, I'm just starting it. Okay, do you have my screen?
Yes.
Okay, are you able to see the presentation?
Yeah.
Okay. So that we would be discussing fluid management for initial resuscitation, and then perioperative management. I will try to make you understand what you think I understand. Neurotrauma includes traumatic brain injury and spine injury. So many times it is part of polytrauma. Sometimes it may be isolated traumatic brain injury also. And there is a lot of difference regarding the management protocols and management strategies when there is other tissue injuries, or there is bleeding somewhere else, or when there is traumatic brain injury in isolation. Brain has distinct physiological aspect because there is a blood-brain barrier, so that it is very different from other tissues where the capillaries and their action are there. And the fluid management will also is depending upon whether blood-brain barrier is functional or not. And the kind of fluid that we are using during fluid resuscitation may influence brain volume, and by decreasing or increasing brain volume, we may decrease or increase intracranial pressure also. So first I will go to normal physiology, how things work. This is the physics. There is a semi-permeable membrane which separates one compartment with the other, so that if the osmol molecules are less on one side and more on other side, they will lead to generation of a pressure which is around 19.5 mmHg for every milliequivalent per liter difference in osmolarity. So that because of this pressure gradient, the water is dragged from low osmolarity to high osmolarity chamber. Because the semi-permeable membrane is impermeable to the colloids or osmoles, so that the pressure gradient drags water only. So colloid oncotic pressure or osmotic pressure is mostly due to large molecules in the peripheral capillaries, and it is mostly due to albumin. Because in peripheral tissue, this semi-permeable membrane permeates the ionic molecules like sodium, potassium, and other molecules, while it is impermeable to albumin. And here comes the difference between the peripheral capillary and cerebral capillary. Here we can see that the gap in the capillary is in the range of 65 angstroms, while in the cerebral capillaries it is much less, only 7 angstroms. So that what happens that although the peripheral capillaries they permeate sodium ions, the cerebral capillaries do not permeate sodium ions, and this makes a lot of difference because the concentration of sodium in comparison to albumin is very high in our blood. So that what happens that the osmotic, most of the osmotic pressure is due to the albumin or proteins in the blood at the level of peripheral capillaries, while at the level of cerebral capillaries it is mostly due to sodium. The osmotic pressure, and now for convenience, the pressure exerted by sodium ions, we will call it osmotic pressure, while the pressure gradient due to the protein or albumin, we will call it oncotic pressure. So that osmotic pressure is much high in comparison to oncotic pressure at the level of cerebral capillaries, so that it is more significant. And accordingly, there is a slight difference between tonicity and osmolality. Now I think tonicity means the comparison of osmotic gradient according in comparison to the uh, our intravascular compartment. So that if it is isotonics, then the osmotic gradient will be 0 in comparison to our intravascular compartment. So we can see here that a slight change in sodium concentration will lead to generation of a large sodium gradient or pressure gradient that may lead to movement of water from or towards the brain cells. Here we can see that if the normal 140 milligram per liter concentration sodium is there, it leads to plasma osmolality of 280, and if the ICF osmolality is also in homogeneity 280, then the pressure gradient is 0. But even if there is a small fall in sodium, that will lead to a greater fall in plasma osmolality, and definitely much greater fall in osmotic pressure or in the plasma, so that the more fluid will be directed towards ICF of brain, so that will lead to brain edema. While there is sodium, when there is hypernatremia or sodium is higher at the range of 145 milligram per liter, the osmolality increases and the pressure gradient is maintained on the other side. So what happens when the brain is damaged? So in an injured brain or traumatic brain, we can see that there can be 3 different compartments, so 3 distant areas. One area where the blood-brain barrier is normal. So the area where blood-brain barrier is normal, the hypertonic solutions will reduce the edema because they will lead the fluid out of the ICF, and the edema will be reduced. There can be other part where the blood-brain barrier is completely disrupted. Here we can see that because these membranes will permeate sodium, so that the effect of sodium will be less, and there will be they will behave like peripheral capillaries. But if it is totally damaged, then what will happen that these solutes or the larger molecules, they can seep out of the capillaries, and they can in fact increase the tissue edema. So there are 3 distinct kinds of brain tissues which we can see over there. Now coming to goals of fluid therapy, what we want to achieve with the fluid therapy. Firstly, we want to reverse the hypovolemia. Second, we want to avoid hypotension or treat it so that we can maintain mean arterial pressure and cerebral perfusion pressure. We should understand that hypovolemia and hypotension, they both are slightly different things. Flow versus pressure concept comes here, so that the cerebral perfusion pressure is in fact more important than the total flow. We need to make efforts to reduce intracranial pressure. We should also maintain the electrolyte balance, acid-base balance, and glucose levels, so that our fluids should include or should be aimed to treat or maintain this homeostasis also. Then there are hemostatic implications. If we give a lot of fluid, that will lead to dilution of coagulation factors, and that will lead to increased bleeding. Then if there is ongoing blood loss, then we have to resuscitate and make our strategies, some surgical intervention to reduce the further bleeding, and along with that the fluid transfusions or fluid therapy should be continued. And we should also take care of other organ systems other than the brain itself and the temperature, because hypothermia is very dangerous in such situations. It can increase the bleeding and it can worsen the outcome. So our goal is ultimately prevention of secondary brain injuries. The first thing which comes to our mind when a patient comes or is having a polytrauma or including traumatic brain injury, how should we resuscitate? So previously there was a restricted approach adopted, where there was concern that if we give a lot of fluid, that may increase brain edema. Now it is established that keeping patient dry does not necessarily dry the brain. In fact, it may be counterproductive. Keeping the patient dry will only decrease 1% of brain volume, so that in terms of ICP, it is not helpful. But there is other problems with liberal infusions. It may cause coagulopathy. It may increase the bleeding because the inadequately formed clots may be removed if a lot of fluid is given. There can be dilution of other factors also and acidosis. But with restricted infusion, there can be tissue or brain ischemia. We can see here if the cerebral perfusion pressure is low, it will lead to decreased perfusion, tissue ischemia, tissue edema, raise in ICP. That will again decrease the CPP. So that it is very important to prevent this vicious cycle establishing. So initial resuscitation includes rapid infusion to prevent hypotensive episodes. So that the purpose is to prevent hypotension. But again, it is very important not to give more than necessary fluid, because if we give more fluid, it will not only lead to other tissue injuries, tissue edema, ongoing bleeding may worsen, coagulopathy may ensue, and the patient may again go into vicious cycle where the coagulation dilution will lead to more bleeding, will lead to more loss of coagulation factor, and ultimately will lead to worsening of the situation. So it is a very tight rope that we have to take. The fluids should be given just adequately that they are required. Now what to give? Crystalloids, we have options between buffered and non-buffered solutions, although no solutions are totally buffered, but relatively buffered and non-buffered solutions. Non-buffered solutions include sodium chloride, while there are many buffered solutions available nowadays. Then there are colloids, natural colloid like albumin, or there are synthetic or semi-synthetic colloids like starches, gelatins, and others. And then the blood products. The most commonly used fluids in neurosurgery or in trauma settings are colloid solutions. The colloid oncotic pressure of these fluids is 0 because molecular weight of solutes is less. The fluids can be hypotonic, isotonic, and hypertonic depending upon the concentration of sodium ion in those fluids. Now we can see that if we give hypotonic solutions, that will cause water shift to the brain interstitium, and that will cause brain edema. The example of these fluids are 5% dextrose that are presently contraindicated in such setting. Ringer latex, although it is hypoosmotic, but it may be given in small amounts, not in large amounts. Isotonic solutions such as normal saline does not produce any osmotic gradient, so that there is no net movement of fluid and it prevents cerebral edema. And this is the fluid which is preferred till now or most of the times. Hypertonic solutions that we use like mannitol or hypertonic saline, they cause osmotic gradient and thus dry the brain or dehydrate the brain. They are used to treat the cerebral edema and also in small volume resuscitation. Small volume resuscitation means that if we give hypotonic solutions, it will drag the water out of interstitial space into the intravascular space and may maintain intravascular volume in a better way. When the small volumes are used, thus we may provide the problems of excessive fluids administration. Now these are the composition of different fluids. This is the composition of plasma. In comparison to that, we can see that sodium chloride contains higher amount of sodium and still much higher concentration of chloride in comparison to plasma, and it is devoid of other ions, so that it is totally unbalanced. Then Hartmann or Ringer lactate, it in a better way mimics the concentration of plasma. Now there are other fluids also available which have low chloride concentration. The problem with sodium chloride is not the sodium but actually the chloride ions, because more chloride may cause more problem that we may see later on. So that plasma light contains less of chloride, and there are other ions like to buffer the sodium, there are other ions like acetate and gluconate, which are converted ultimately to bicarbonate in our body. So it is said that only 1/3 of crystalloid remain in intravascular space. 2/3 of colloids seep out in the interstitial space, so causing interstitial edema. But nowadays it has been questioned. It may cause fluid overload. Again, it is questioned if it is given judiciously. It does not cause much fluid overload or may not cause fluid overload. There is peripheral tissue edema. There can be pulmonary complications because the fluid may seep out to the interstitial space of lungs also. And there is no crystalloid which is exactly similar to the plasma constitution. So there is no crystalloid is balanced enough. Now the most commonly used fluid is sodium chloride. It is an isotonic solution, but the problem is that it can cause dilution hyperchloremic metabolic acidosis. Hyperchloremic metabolic acidosis is caused not only because it contains high chloride, but also because they are stronger ions. While the plasma has weaker ions like bicarbonate and other ions, the chloride ions are very strong, so that other than hyperchloremic acidosis, the pH is decreased much more. And there are many postulated adverse effects of these metabolic acidosis. They range from GI disturbances like nausea, vomiting, to renal side effects like decreased GFR, decreased urine output, or retaining of other ions like sodium. But there are no evidence of clinical consequences of hyperchloremia. And it is sometimes said that it is more an ABC or laboratory value rather than the actual problematic thing. Decrease in GFR and decrease the increase in or probably worsening of renal function counts at very high level when the fluid is given or normal saline is given more than 50 ml per kilogram per hour. And if suppose a 60 kg man receives 50 ml per kilogram per hour normal saline, it means 3 liter of normal saline every hour. And this much of fluid is required usually when there is severe bleeding. And again, this is an indication of blood transfusion. Now, Ringer lactate, it is slightly hypotonic solution, so that it should not be given in large quantity, but it can be safely given in small quantities, because lactate given may be converted into bicarbonate and thus can actually reduce the problem of acidosis. Newer crystalloids where chloride is replaced by other ions, but we don't have many studies showing their safety. But there is increase in use. In fact, we are using more newer crystalloids when higher amount of crystalloids have to be given. Carbonate are converted to bicarbonate so that osmolality does not change. But there is again a risk of alkalosis. Perioperative buffered versus non-buffered fluid administration for surgery in adults. There was a review in Cochrane. There was a Cochrane review in 2012, and it did not show much difference. Now coming to colloids. the natural colloid or human albumin, and synthetic colloids or semi-synthetic colloids like starch, gelatins, and others. So that albumin, as albumin is natural, so that we can consider that it might be the best volume expander that we may give to the patient, and by this way we can decrease the total amount of the fluid that we are giving, and the complications of the high fluid infusion related to their seeping out of intravesical compartment to interstitium. They are good volume expander. Small volume is required, but there can be hypersensitivity reactions. Coagulopathies may be there. There may be renal toxics, and if they get out of the capillaries, they remain there for long time because they are absorbed very slow. So that they can, if they are seeping out of the capillaries, they can lead to excessive edema, or in cases of neurosurgery, excessive brain swelling and raise in ICP. Albumin is natural, it has long half-life, and because it is natural, it has less allergic reaction, less coagulation problem, but the problem is that it's very, very expensive. Then dextran and gelatin, they are less useful as they cause coagulopathy. Starches, they have very high allergic reactions. So to establish the safety of albumin for fluid resuscitation, it was studied in SAFE study, and it showed that although the short-term survival was there was better survival with saline in comparison to albumin, and this difference persisted long time or in long run. So resuscitation with albumin was associated with decrease in adjusted risk of death at 28 days in patients with severe sepsis, and no significant difference in hemodynamic resuscitation endpoint was there, although the use of albumin was associated with a significant but clinically small increase in CVP. So that the point is that we were giving albumin considering that it can maintain the hemodynamics better, but in fact it did not occur. They both remain the same. The second thing that why we gave albumin was to decrease the volume of fluid that we are giving. But it was seen in both the groups that the ratio of albumin to normal saline was only 1 to 1.4. So that the concept that we may have to give less albumin or less amount of colloid if we do not use crystalloid, or if we restrict the use of crystalloid, was not established. When other sub-analysis groups were done, it was seen that resuscitation with 4% albumin was associated with increased ICP, specifically in the first week following the injury, and it was postulated that this is because of this increase in ICP, the mortality was higher in this group of patients. Resuscitation with albumin was also associated with greater use of intervention to reduce ICP, in particularly sedative, analgesic, and vasopressors to maintain CPP. So that when we saw that albumin is not good enough to use in traumatic brain injury patients, then what is the status of other semi-synthetic and synthetic colloids? Because it was said that because albumin gets out of the capillaries more easily and may lead to raised ICP. So what will happen if we give even larger molecules like HES? But the problem is that their safety is also not well established. Most of the studies that are done with semi-synthetic or synthetic colloids are done in sepsis patients. HES is associated with coagulation problems and acute renal injury. Now there are more results in critical care setting coming up, like Scandinavian study and chest studies, that does not show much difference in hemodynamic goals or achieving the hemodynamic goals. In fact, in the chest study, it is seen that the ratio of normal saline, so it is actually other way around, the ratio of HES and normal saline was just 1 to 1.3. So that what we said that the crystalloids have to be given, colloid does not stand. The safety profile of gelatin is not established at all. Synthetic colloids are without superior, so that it is this statement regarding the safety and efficacy of colloid resuscitation in critically ill patient, I want to say that we cannot extrapolate this data as such in trauma patients also, but again we have our concerns regarding the safety and efficacy of colloids. Synthetic colloids are without superior effect in critically ill adults and children, but must be considered harmful depending on the cumulative dose administered, because there are safer and equally effective alternatives in the form of crystalloids. We question the use of synthetic colloids outside the context of clinical studies. In fact, it has also been said that the chest study did not include or try to avoid the traumatic brain injury patients because the authors or the investigators had preformed hypotheses that they may be more dangerous or deleterious in the situations of traumatic brain injury. So what we can say that there is inadequate literature about the safety of synthetic colloids in traumatic brain injury patients. The recent studies question the safety of starches as such in all the patients, and synthetic colloids should be avoided in a patient without traumatic brain injury also. Even some more in traumatic brain injury patients, but also in patients without traumatic brain injury. Now, other strategies like transfusion, when should we transfuse? There is lack of evidence. Although it has been said that oxygen delivery is optimal at hematocrit of hemoglobin of 10, it is not well understood whether blood transfusion at this level reduces the mortality. It is a different thing. Most of the studies are done to see at what transfusion level there is greater risk of injury. But there are even much less study which show that transfusion at what particular level may decrease the mortality or the severity of injury. But what we think is that in acute setting, when there is polytrauma, we should maintain the hematocrit around 30. Then hemostatic resuscitation. It is very, very important that when we are giving crystalloids in the amount to resuscitate the patient, it will definitely dilute the intravascular compartment. The clotting factors will be diluted. That may lead to increased bleeding. So that if there are facilities available, we may get the fast investigations done like TEG or ROTEM. But if the facilities are not there, we should do hemostatic resuscitation. It means that after 4 units of packed red cells, we should give PRBC, FFP, and platelets in the ratio of 1:1:1. Permissive hypovolemia. Nowadays, it is being propagated that pre-hospital crystalloids may worsen the outcome because of the factors that I said previously. But its role in traumatic brain injury is not certain. Although there is a small study which has shown the safety of permissive hypovolemia in these patients, but it is not established practice. Probably in coming time we will have more evidences regarding this. But when the patient is arrived in a hospital and when we are managing it, I don't think there is any role of permissive hypovolemia at that point of time. We should resuscitate the patient adequately, maintain the hematocrit and coagulation condition of the patient. Low volume resuscitation, I have spoken to it on this topic previously. Hypertonic saline has been used. It is useful in field situations like in military operations or in mass casualty where adequate amount of fluid is not available. But otherwise, the use of low volume resuscitation is not established, because in a few studies it has been shown that even with the patients with traumatic brain injury, where it may decrease ICP, the outcome is adverse. Again, when we are giving fluid, we should mind this and consider this, that we should achieve adequate glycemic control. The preferred range between being between 90 to 150 mg/%, and use of vasopressors. When there is poorly responding shock, when there is presence of cervical spine injury or brainstem injury, it is better to use vasopressors in comparison to giving a large amount of fluids, crystalloids or blood or other products. So that when we estimate that there is peripheral vasodilation that is causing the hypotension, it is better to use vasopressors at that point of time. The fluid discussion cannot be completed without a discussion on osmotic agents. Hypotonic, saline, and mannitol are used to reduce ICP transiently. In traumatic brain foundation guidelines, it has been said that mannitol should be used to reduce the ICP. Although there is no mention of hypertonic saline, but in a case of polytrauma or hypovolemia, 3% hypertonic saline is more beneficial because it will help in maintaining the intravascular compartment volume. Mannitol because it causes diuresis, vasodilation, and also electrolyte imbalance. And because hypertonic saline because of high chloride ion, the sodium is also well retained, so that it may help in such acute situations. Volume replacement and correction of electrolyte imbalance is important if we are using mannitol or hypertonic saline or other agents also. The traditional methods of assessment and monitoring the fluid management was to record vital signs, urine output. They stand true even today, although we should understand how they act when the vital signs become abnormal. It is actually a bit late, so that we need to act proactively and should try to maintain vital signs before they deteriorate. And many a times vital signs can be confounded by Cushing reflex, brainstem injury, or cervical spine injury. Urine output may be misleading because the patient might be receiving mannitol or Lasix, so that we should also consider these factors when we are monitoring the patient. CVP has shown a very poor correlation with intravascular volume over a range of CVP. And again, when the patient is intubated and is positively ventilated or ventilated with positive pressure, the CVP may be poorly correlating with intravascular volume. Dynamic parameters are better indicators like pulse pressure variation, stroke volume variation, or respiratory variation in the pulse oximetry plethysmograph. And nowadays we are depending more upon these dynamic parameters because they show volume responsiveness. The use of ultrasonography and echocardiography in developed center is actually should be used more often because they show us the status of intravascular compartment directly. The attempts have been made to monitor the patients and their oxygenation parameters and serum lactate. So, but they are in very initial stages, and we may see the development of these monitors in coming time. So, conclude, cerebral dynamics is different from rest of body. The emphasis of the talk is to maintain MAP and CPP while giving just adequate amount of fluid. Osmolarity should be monitored and maintained. Hypoosmolar fluids are contraindicated in traumatic brain injury. Newer crystalloids, they look attractive, but they need more studies. Colloids should be avoided, and definitely more studies are required as usual. Thank you.
Thanks, Manish. Thanks for that wonderful presentation. And Dr. Prasanna, can you moderate the discussion? Dr. Prasanna? Yeah, Manish, hello.
Hello.
Dr. Manish, can you hear me?
Yeah, in just a minute. Screen share is not getting off. Okay.
Yeah. So, in most of the ICUs, if you see now also, the practice of fluid management is like there'll be a column where they maintain a positive or negative balance. They just calculate whatever comes out as negative and whatever goes in as positive. So, how do you approach this scenario, and what is the scientific rationale on how to approach this kind of calculating input outputs?
This kind of calculation came into practice when we didn't know much about how fluid or how the body responds to the fluid. So that what we thought that if we compensate the output, urine output and other outputs and insensible loss and give it as input, then we are taking care of fluid management adequately. But now when we have more monitors and more things to guide our therapy, then although that can be helpful, but it should not be the only way how we monitor the fluid. We should take consideration of the patient condition, patient situation, and how he is responding to the fluids that we are giving. And again, the dynamic parameters. And if the requirement is there, we can add additional monitors or advanced monitors to guide the fluid therapy. We should not fluid. It is just like we should not give fluids like it is just water. Actually, it is also a medicine or a treatment that we are giving. So it has to be given adequately and very thoughtfully.
So regarding your discussion on 3% normal saline, what is your practice? Because we have got only 3% of saline commercially available. How do you target the sodium, and what is your protocol of achieving the target sodium? How do you do that?
When we are using 3% saline, we are using it in certain circumstances, like as I said, then when we suspect there is hypovolemia and mannitol can cause more harm than benefit by decreasing the intravascular volume, or other situations when we are using hypertonic saline, we have a targeted value of sodium of 155. Because I think that if it goes beyond 155, then it may increasingly get, or I have experienced that it gets out of hand sometimes. So that 155 seems very reasonable and safe, and most of the times we can maintain this level without much problem. And then I calculate how much sodium has to be given, and then we give it by infusion and or by boluses, and we try to achieve that level, so that it is more about the level that we want to achieve rather than the total volume of the fluid or 3% saline that would be used.
So most of the time, what we observe is whenever we give boluses or start infusions, still, it will be very difficult to maintain the sodium levels. Maybe it is getting lost by the urine, or do you add fluorocart and adjuvants to that to maintain the sodium?
No, I have not used, although there are many articles which say that they use adjuvants or adjuvants may be used, but till date I have not used, and it may take slightly more time to achieve a level, but we usually achieve the desired level in probably a few hours.
And regarding hyperosmolar therapy as such, the traditional practice is to give mannitol for 3% redness. We can monitor the sodium, and to consider the efficacy of mannitol. Do you monitor serum osmolarity or the osmolar gap, and is it a standard practice? And what would you suggest?
We are not using it, and neither it is a standard practice. So that I am not able to comment upon this because I'm not experienced in using these tactics. But I feel that the more important thing is the patient response in terms of ICP, so
Okay.
that it is better to monitor it directly.
Dr. Prasanna, are you there? I'm not able to see your webcam. Okay. So, considering this in a scenario, an isolated head injury, what would be your advice of fluids?
Yes, for isolated hair injury, we need not resuscitate the patient excessively, because there is no, if there is no deficit, fluid deficit is not there, and there is not active bleeding, so that we can constrain the use of fluids. We can use crystalloid just as to replace the losses.
Okay. And regarding blood transfusion in trauma, nowadays we use very restricted fluid, and even in with the polytraumas, things like that, we start early transfusion in the ratio of 1:1:1. So you think this should be applied to a head injury as well during intraoperative management of a head injury?
Yes, I
Means
think
we
that,
should receive
yes,
the blood transfusion earlier than later, which was the practice earlier.
it is not doing blood transfusion earlier. See, uh, actually, we do not know. We know that anemia causes problem. Anemia is associated with adverse
No,
outcome.
not only anemia, but the coagulopathy as a result
Yes,
of trauma as well as a result of more fluids and
yes.
hypothermia.
First, I'm talking about hemoglobin, or to substitute the blood transfusion with the blood loss. So, although we know that anemia or blood loss, increased blood loss is associated with adverse outcome, but we do not know at what level blood transfusion will reverse or will prevent this problem. So, because blood transfusion itself has many or has a potential of many adverse outcomes or adverse effects. So, by going conventional way, it is said that maintaining hemoglobin of 10 is important because the oxygen carrying capacity is optimal at this level. We don't have any other evidence regarding this. So it is actually lack of evidence that has led us to the practice of maintaining the hemoglobin of 10, and we stand by it even now. Now, giving blood early is not good because by practicing this, we may over transfuse the patient. So, but hemostatic, as you say, that hemostatic transfusion should be there. I think it should be there.
Yeah.
There is no problem because the traumatic brain injury will lead to deterioration in coagulation condition of the patient anyway. So that we have to maintain that. So that's why I said that if possible, we should monitor those patients and then try to treat them.
Okay, Dr. Prasanna, I can see you here.
Yeah,
Please add your
yeah,
comments in the discussion.
yeah, it was wonderful. I just wanted to know from Manish, there is ongoing debate, but now most of the people feel hypotonic saline is better than mannitol. So is it really true, or what is
No,
the
no,
why?
hypertonic.
Uh,
No, I don't think that hypertonics it is established or there are enough evidences to say that hypertonic saline is better than a mannitol. I just said
okay,
that by going with the physiology of the fluids, it seems that hypertonic saline may be used in certain circumstances like hypovolemic conditions and the conditions where mannitol we are worried or we are concerned about the adverse effects of mannitol. So in those situations, we can give hypertonic saline, but as of now, we don't have enough evidences so that we can replace mannitol totally with hypertonic saline.
no, the recently come traumatic brain injury guidelines. Do they focus on anything on specifically
No,
hypotonic saline?
no. No. They have not focused. They have not mentioned
Hmm.
because there is lack of evidence. They are based upon evidences, and there is lack of evidence, so that there is no concrete statement by them.
Okay, so the mannitol still is going to be the first choice, right?
Yes, yes.
Yeah. But, how routinely do you monitor the osmolality when you're doing? Is it by ABG or is it by calculation? How do you monitor?
We do not monitor direct osmolality often. We calculate osmolality depending upon the various ions that are present.
Yeah.
Because in most circumstances that is the same. There are very few situations where the calculated and the estimated values will differ. And
No,
polytrauma
because
is
mannitol is this one, no? Osmotically free osmoles, like there is no ions. So we calculate it when we do a mannitol. It needs to be
no.
measured.
We do not monitor the effect of mannitol by measuring the osmolarity.
Yeah.
Now, if at all we want to monitor the mannitol efficacy by monitoring the serum osmolarity. It said that it's better the osmolar gap between the serum and the urine
Oh,
rather than going on the basis of serum osmolarity. But it is not a
yeah.
standard practice in most of our Indian ICUs. Maybe we can start implementing that if at all we given a mannitol therapy. But in the current practice, the absolute indication of mannitol is only in case of intracranial hypertension as a time buying, the time buying time where we establish a therapy like a patient is coning and going for decompressionectomy, we give mannitol. That's only the absolute indication. There are other indications where it is being practiced routinely with lot of cases receiving mannitol day in and day out for no absolute indications. In those scenarios, it's better to monitor the osmolar cap, and we can by that we can really prove that the mannitol is working or not working.
This the prediction of blood loss and checking for hemoglobin in the intraoperative intervention. Do you use continuous measurement of the hemoglobin, or do you believe on the hematocrit found in?
And we do not have facilities of continuously monitoring hemoglobin, so that we will do it continually by doing serial APGs or lab values.
So what is your
how
practice,
do you
Dr.
decide upon the transfusion trigger?
What is your practice? You have a hemoglobin target, or you go by the individual patient's hemodynamics and some some endpoints for
we have
transfusion?
a hemoglobinometer which intermittently we can measure on the bedside. It's like a glucose stick.
So what is your target?
I feel it is 10. I start when it is less than 10 because the underlying blood loss, lot of factors it depends on cerebral edema. And, so I start transfusion when it is less than 10. Do you have any other this one, Manish? Is it 10 or you will wait for some more?
No, it is 10 by default, and we don't have any other evidences to remove it from default.
Is your practice is replacing the ringer lactate and NS by plasmalite, or it is still going in the way of
No, for past
NS and occasionally RL?
For past some time, what I am doing is that when I think or I estimate that I will have to give a lot of colloids, I use plasmalite in place of ringer lactate or sodium. The ABGs remain the same. I have not compared it with any study, so I cannot comment upon this. But I feel that it is slightly better than giving the normal saline alone.
So I don't think there are any studies also so much in traumatic. In the trauma setting, there are several studies, but in such in traumatic brain injury and also in the elective neurosurgical operations, the studies are lacking. Most studies related to this plasmalite and all are in the patients with renal failure, hepatic failure, transplant patients, and all. The neurosurgical patients. Something we need to look upon and try to do the studies on this. If at all you are using a colloid, when you use and which one you prefer? Because you have a lot of options to us. What is your practice?
I have used around 2 or 3 bags of colloids in last 1 year. So that I am not using colloids. I have used only in certain circumstances where I am waiting for the blood. The patient is going down fast, and I need to give something to expand the intravascular compartment. At that time, I give HES, but because I am using it much less frequently, so that it is better to avoid colloids at all.
Okay. But I don't think there are any studies directly with giving colloids, particularly HES or something related to the higher renal injury and renal failure, like as it is in the patients with sepsis or so, where there is an increased incidence of renal failure. Is it, have you come across any study like that? And
no, there are no studies where because it is almost not in practice. Like they have stopped using colloids for volume resuscitation all over the world. The use of colloids has drastically reduced with time. So that I don't see that there will be studies recent times regarding this. Because the safety profile is challenged in other patient groups. So that again, it is difficult to use them in this patient group as well.
Okay. As Dr. Ponniah pointed out, only 3% hypertonic saline is available in India. But when you look at the studies, even 23.4%, 29% has been used. Do you think availability of these solutions like 7.5%, 11% makes a difference to our management in Indian setup, or are you reasonably happy with 3%?
I'm happy with 3%. Because I mean 3% is also used in not very high amount. The only benefit of using higher concentration is using less volume.
Okay.
But again, 3% also provides much lesser volume. I mean, much greater concentration, so that we
Do
have to
you
use
use
much
it as
lesser
a
volume.
bolus like mannitol, or use it as a continuous infusion in patients?
We give usually as bolus, but also as infusions, especially in pediatric patients.
Okay. So there was a slide particularly focusing on hyperchloremic acidosis, metabolic acidosis.
Yes.
What I read all these days that is more of a theory than practice. Some problem happens clinically. Is it true, or still there is a risk of renal injury?
There was few animal studies, one or two volunteer studies where they showed that GFR is decreased by because of high concentration of chloride. So what happens that if you give chloride, there is a risk of retaining other molecules like sodium and other things also. And in a way, I don't think it is a problem. Actually, it is sometimes of an advantage, because we can maintain the intravascular volume better. We can maintain the greater concentration of sodium at that particular time. But there is no evidence that it decreases or increases the creatinine concentration.
Okay.
So,
Dr. Manish, Dr. Saurav want to ask if there is a role of fluids like sterofundin in traumatic brain injury.
your guess is as good as mine, because there is no evidence available. Although theoretically it seems good, although it has slightly higher concentration of chloride, but again there is no evidence. So that what can I say?
So
Okay,
there is,
Dr. Prasanna, we were discussing earlier when you're not there about in trauma, which is now the standard of care. So, in regards to head injury, when we extend that to the operating room from the ER,
yeah.
now what is the current practice you are practicing, and what would you suggest our viewers on practicing? What are your views? When this patient comes for a decompressive craniotomy or evacuation of hematoma, and there is a breath loss, what kind of strategy you employ?
Yeah, I
You
start.
use the same hemostatic resuscitation with 1:1:1 with blood products.
No, I don't use it simply because I have no luxury of getting all those products so easily as Dr. Manish or you can get. So, but that's the reality. But I start with crystalloids, and so there are two aspects here. When the patient comes for decompressive craniectomy, I would like to see the scan and assess and how much amount of the blood loss is happening, which is very difficult to predict. Definitely, I use blood more liberally because it's very difficult to assess the exact hemoglobin status of the patient, whether it's anemic or not. But my practice is same of a routine, but we have ABG machines available, and we go by the trend, how the XP is going on and the osmolality. My routine practice will be to use the crystalloids and blood more liberally than the other cases, like to
No, you
surgical
mean to
patients.
say you don't use that 1:1:1 formula? Means you give only blood.
No, 1:1:1 formula I don't use. I rely more on my clinical skills, whether the oozing is more or the surgeon is complaining of increased bleeding. Because
No,
within the start,
most of them, it manifests as an expansion of hematoma or low platelets in the post-operative period. By the time, don't you think it will be already too late? Because
empirical,
this is very well proven in trauma scenario where the hemostatic resuscitation
yeah.
plays a vital role.
Yeah, so there is a difference here. The hemostatic resuscitation 1:1:1 is more like which is sought out for massive transfusion protocols when there is a massive transfusion, and in those settings, than in the settings of traumatic brain injury where the blood loss may be around 1 to 2 liters, not more than that. So that is different from the coagulopathy induced by the brain injury, like tissue thromboplastin is released and brain injury is happening.
No, isn't that the reason? Isn't that more the reason to use 1:1:1 transfusion? Because we have head injury as well, which itself.
Because it doesn't happen in all the patients. That is the reason. So what is the incidence? It doesn't happen in
Are
all
there
the
any
patients.
studies, or it's just your individual opinion?
I'm not aware of any studies because it is difficult to predict which patient is developing the going to go for
Coagulopathy.
coagulopathy. So it's more of a clinical skills like excessive bleeding, what you are seeing in the intraoperative period. Than
Do you
the
use
usual.
thromboelastogram routinely?
No, we are acquiring in the process of acquiring a sonoclot now. So maybe we'll use also.
How about Manish? Do you use thromboelastogram?
Yes, we have a luxury of having TEG in our OT. The other thing that I want to say is that, as I said, hemostatic resuscitation is usually done after you giving 4 units of PRBC. It is almost a thumb rule. Not it has to be followed every time. But when we have already infused 4 units, it means that there is massive blood loss, and then we need to replace in the ratio 1:1:1. So they usually wait for maybe 2, 3, or 4 units depending upon the situation of the patient, and we do not give FFP and platelet with the first unit of PRBC itself.
Yeah. And because this 1:1:1, if I go by that, in a particularly trauma setting also, most of these studies are from the Iran-Iraq war and the US-Afghan war and all those things. So most of these are retrospective series and where they are found. So all the studies, even the retrospective, they do not concentrate on 1:1:1. There is 1:2:2, 1:2, 1:1:2 like that. So it is not entirely true that all the patients we give empirically 1:1:1 and thinking that we'll get away with it. So it has to be matched with the clinical and laboratory parameters before going into it. So if the laboratory parameters are difficult to get or very fast to get, like a TEG is not available, so clinical skills, and maybe we may err on the right side and give more products as compared to routine.
Okay, Dr. Manish, what about tranexamic acid and
Yes.
antifibrinolytic in head injuries?
It can be given, but again, there is lack of evidence of giving tranexamic acid in such patients, but it can be given. It has a supplemental role. When there is excessive bleeding, it should be given. But preemptively for every head injury patient, it has got no role.
Dr. Prasanna, you want to differ or you accept this?
Yeah, I would like to differ. I think I feel to give to each case tranexamic acid. So once the bleeding sets in, a picture of DIC or something like is there, I don't think there is a big point in giving tranexamic acid and it does some wonders. So tranexamic acid is best useful when you give it in the pre-operative period before starting the surgery. So, and tranexamic acid is the only agent which has shown in the polytrauma and trauma settings also, which has improved even the outcome of the patients by reducing the blood loss. Whereas the other factors like costly factors like factor 7A and recombinant factor 7A and others, they have found to reduce the need of the blood transfusion, but not much affecting the outcome. Whereas the tranexamic acid is the one which has shown. So I think I would use liberally tranexamic acid. So initially I was using 10 milligram per kg bolus. Now we have moved on to around 20 milligram per kg bolus.
So when do you use that?
1 million. Yes?
When do you give that?
It's before 20 minutes before starting the surgery. Post induction we start it, and by the time they clean and they scrub and start.
So you're doing it routinely for all the patients?
Yes, even in the elective neurosurgical operation.
Okay. I don't know how many will agree to that, but Manish, do you agree to that? Using routinely in all the patients?
I will have to take a look at evidences. No, I'm not sure, but I will have to. I'm not.
The incidence of DVT, increased incidence of DVT and all, I think not very well documented with tranexamic acid.
Okay. But how does it? Does this practice has brought down the transfusion requirements in your patients? You think so?
Yeah. If you see subjectively, yes, true. But we did a study on this low dose tranexamic acid, 10 milligram per kg in elective neurosurgical patients, and 100 patients, 50 in each group. So it was found that definitely it reduced blood loss intraoperatively, but the transfusion requirements were similar in both the groups. So then I thought maybe we are giving a lesser dose. So that is the reason I moved on to 20 milligram per kg now. So
I think it is more of a subjective thing. I think because not that all neurosurgeries are the same, and
yeah.
actually we need to
So,
group
but
the
triaxamic
patients where.
acid has been shown to reduce the blood loss and requirement even in the craniosynostosis.
No, it is true
So
that it
there is
can decrease the blood loss, but again, the adverse effects associated with tranexamic acid also need to be considered or should be included in the various studies. Because suppose, and we cannot give it to every patient, like the patient who is having some CAD or some other issues with thrombosis, and we are giving tranexamic acid blindly, and we will end up with some problem. Then
because the tranexamic acid is a standard practice even in during now cardiopulmonary bypass, gynecological surgeries, everywhere the tranexamic acid role is there. Kyphus scoliosis surgeries.
no, I
I think a
agree with
reasonable
spine
set.
surgeries. I agree
So
that
Okay,
there are
I think we need more studies and more data on especially neurosurgeries to say that we can
yeah.
use it or not. And
In fact, there was a study done in AIMS, All India Institute of Medical Sciences. In meningioma patient, tranexamic acid was given. The results are very similar to our studies. I think it is to be published. It is going to be published. So.
no, the other important point is when you use a lot of mannitol and stuff like that, we get a lot of urine output.
Yes.
And even in the ICUs during the recovery phase, the urine output is going to be an issue. How do you manage the urine output? Are you going to chase the urine output by giving more fluids? And what is your strategy on how do you manage your fluid, Dr. Manish?
we do not go to chase the urine output. As I said, that we more often use the dynamic parameters and other parameters as well to guide the fluid therapy. It is not only the urine output, just going by urine output. And if we give mannitol, then we are anticipating higher urine output, so that we take that into consideration.
So you mean to say it's more of intravascular volume which we like to maintain
Yes.
by whatever ways possible you can monitor and maintain that.
Yes.
Dr. Prasanna, your thoughts on that?
Sorry, I missed the question. On?
Because more of times when you use mannitol and even during the recovery phase in the ICU, we get a lot of urine output.
We don't chase it. We don't chase this, that urine output, but we'll try to maintain the urine. If I find it is too much irritating to manage such patients, I give a single transnasal puff of desmopressin, 10 to
Why do
20
you want to
mics.
do that?
That works well. That slightly reduces the urine output.
No, but this is not a hypotonic urine. It's not a hypotonic urine. It's not a hypotonic urine. Because when you give those things, then more likely the patient can develop a transient hyponatremia, things can retain water.
One
Why
dose.
do you want to reduce that?
No,
If
one
your
dose.
intravascular volume is adequate,
So
you really want to use
that is the issue. Maintaining the intravascular volume itself is the issue when you have so much urine output. So definitely it is going to come down. So I just use arbitrarily. I don't know. I may be wrong in practice also. I arbitrarily use it, and it works well. But I'm not too sure.
It works to reduce the urine output, but does it help the patient also? It may decrease the work and difficulty of the treating doctor, but what about the patient?
It decrease the purpose of the purpose of giving mannitol.
As long as you are able to maintain the osmolality, I think it should be fine. If you are giving a hypertonic saline, 30 ml per hour,
but if you are nasal giving desmopressin, it is a long acting thing, and I don't know.
Yeah.
Okay, maybe it reduces the urine output. I don't know. Okay. So, anything else?
How many times do you use the Lasix, Manish, along with the...
No, we are not using Lasix at all.
Yeah, this is a very important question. Lasix, it's still a lot of, maybe it's more popular from the surgical side. A lot of people believe in Lasix. I don't know for what purpose they believe in. And but it is being used in neurology, neurosurgery, even in OPD prescriptions and things like that.
We have stopped, totally stopped.
But maybe there are no studies or no guidelines which recommend using that now comes. But still, from the older times, by the inheritance of practices and it's being still used a lot. But what does the TBI guidelines say? Does it mention about
No,
Lasix?
no.
No, it doesn't mention.
As much I have read, there is no mention. Professor Prasanna will tell in a better
Dr.
way.
Prasanna, what is your take on that? Lasix, using Lasix in neurosurgical practice. You know, on critical care.
Yeah, in ICUs we don't routinely give. In the intraoperative period, if I find the urine output is not sufficient enough, brain bulge is there and you are given mannitol, I give a small test dose of Lasix around 5 mg, which increases urine output, and that works fine. That is optically, I think most of the people use it in the intraoperative period like that, but not in the ICU settings.
Okay, Dr. Manish, if there are no more questions, shall we wind up?
Yeah.
Yeah, and thanks, Dr. Manish, for that excellent presentation and for the hard work you have put in to prepare such a wonderful presentation. I hope it will be very helpful for the postgraduates and the exam-going fellows. Okay. Dr. Manish, thanks for Dr. Prasanna, thanks for coming on the show as usual. Your presence made a great difference. And thanks for all the viewers who watched online or who's going to be watching it later. And thank you so much. And follow us on our classroom Facebook page. You can join our chat room in WhatsApp. You can post your questions. And we'll be coming with more and more interesting topics. So we wish you a very happy Deepavali the coming week. And take care and goodbye.